Hi, my name is Brian Jose Locedeño Quijije, and I'm going to talk about COVID-19 cases, coagulopathy, and antiphospholipid antibodies in patients with COVID-19. Definition: antiphospholipid antibodies abnormally charged phospholipid proteins, and the presence of these antibodies is central to the diagnosis of the antiphospholipid syndrome. However, these antibodies can also arise transiently in patients with critical illness and various infections. The presence of these antibodies may rarely lead to thrombotic events that are difficult to differentiate from other causes of multifocal thrombosis in critical patients, such as disseminated intravascular coagulation, heparin-induced thrombocytopenia, and thrombotic microangiopathy.
In patients with COVID-19. In this study, they describe patients with COVID-19 and clinically significant coagulopathy, antiphospholipid antibodies, and multiple infarcts. In this study, they have one of three patients with three findings in an intensive care unit designed for patients with COVID-19. This unit, which has managed by multiple disciplinary team from Peking Union Medical College Hospital in the Sino-French New City branch of Todji Hospital in Wuhan, China, was set up on an emergency basis to accept the most critically ill patients during the outbreak of COVID-19. Severe acute respiratory syndrome is coronary virus 2 or SARS-CoV-2 infection was confirmed by all the patients by reverse transcriptase polymerase chains reactions or RT-PCR assay or serologic testing. A 69-year-old man with a history of hypertension, diabetes, and stroke present with fever, cough, dyspnea, diarrhea, and headache. COVID-19 was diagnosed in the patient on January 25, 2020 on the basis of RT-PCR testing that detects SARS-CoV-2. The initial treatment was supportive. However, the illness subsequently progressed to hypoxemic respiratory failure, warranting the initiation of invasive mechanical ventilations. On examination, the patient had evidence of ischemia in the lower limbs, bilateral as well as in digital 2 and 3 of the left hand. Computed tomographic imaging of the brain showed bilateral cerebral infarcts in multiple vascular territories. Pertinent laboratory results on admission of the patient to the intensive care unit are summarized in the table of the original texts. They include leukocytosis, thrombocytopenia, and elevated thrombin time, and also partial thromboplastin time, and elevated levels of fibrinogen and D-dimer.
Applications in medicine. A 19-year-old man with a history of hypertension, diabetes, and stroke presented with fever, cough, dyspnea, diarrhea, and headache. COVID-19 was diagnosed in the patient on January 25, 2020, on the basis of RT-PCR testing that detects SARS-CoV-2. On examination, the patient had evidence of ischemia in the lower limbs bilaterally as well as in digit 2 and 3 of the left hand. Computed tomographic imaging of the brain showed bilateral cerebral infarct in multiple vascular territories.
Welcome back to the Critical Care Survival Guide. Today we're going to be talking about a topic that is very important with regards to COVID-19, and that's coagulopathy. We have been seeing patients come in with COVID-19 disease and they're developing clots. Clots both in their micro vessels inside their lungs. We have data from autopsies when they've dissected the lungs and looked in. They're seeing both microthrombi clots, but occasionally larger clots and larger blood vessels in the lungs. Then, as you may have seen in your patients, we're seeing DVTs, pulmonary emboli, and the like. So the question we're going to tackle in today's guide is maybe why is this happening and what can we do to be preventing it? So first, why is this happening? COVID-19 causes a ton of inflammation in the body. You're seeing the inflammatory markers. The D-dimers are going up, CRPs are going up, fibrinogens, etc. So we know that inflammation is one of the big risk factors for forming thrombi. In addition, patients that are in the hospital, they're not moving very much. They're in bed, lying flat. They can't breathe, so sometimes they're having to be put on ventilators because of oxygenation problems. When all that happens, that immobility combined with the inflammation of this disease leads to clot formation. So what are some things we should be doing to combat this? Well, number one, we need to be aggressive with DVT prophylaxis. What do I mean by that? Well, you got to start it earlier than we've been starting it, like in the emergency department. In addition, those D-dimer levels, they go up in this disease, so it's hard to know for sure how we should respond to elevating D-dimer levels. That being said, what a lot of people are doing with their chemical prophylaxis is they are starting people on low molecular weight heparin. That's a little bit better than unfractionated heparin because you don't have to go in the room so much. You don't have to check those PTTs like you had on unfractionated heparin, and it's very reliable in how it works to prevent clots. Patients who have rising D-dimer levels in spite of being on once daily low molecular weight heparin, a lot of people are moving them to BID and increasing the dose. So say, for example, if you were to start at 0.5 mg per kilogram on your DVT prophylactic dose, you might consider increasing that to maybe 0.8 or even 1 milligram per kilogram in divided doses for prophylactic dosing. On top of that, a wise move would be to check an anti-factor 10A level. This is how we monitor the amount of anticoagulation you're getting with your low molecular weight heparins. We're typically checking those 3 to 5 hours after their third dose. That way you know your drug has hit steady state.
Pros and cons. Pertinent laboratory results on admission of the patient. Cons. They include leukocytosis, thrombocytopenia, and elevated prothrombin time and partial thromboplastin time, and elevated levels of fibrinogen and D-dimer. Pros. Lupus anticoagulant was not detected in any of the patients, although testing was performed while the patients were actually ill.
So another really good question, one where there's quite a bit of research actually being put out there, and one that we've already at the Thrombosis Research Group been engaged in trying to look at this. So it looks like COVID-19 has a number of ways that it impacts blood clotting. When patients contract COVID-19, if they suffer a superimposed either pneumonia or other type of bloodstream infection, they have the risk of going into something called disseminated intravascular coagulation, or DIC. And that's a condition that's associated with bleeding. You consume your platelets, it becomes harder and harder for the body to stop bleeding, and there's a hemorrhagic response. That's really one of the most severe manifestations of a COVID-19 infection with a superimposed bacterial infection or a systemic inflammatory response. For other patients who suffer from COVID-19, the immobility associated with the virus, or the fact that these patients are being admitted to the hospital and or the ICU will increase the risk of venous thromboembolism in general. There's some suggestion that COVID-19 may rev up the coagulation process by increasing some of the coagulation response. D-dimers are increased in COVID-19 infection. And so that might be a process where there might be a tendency towards a prothrombotic state. But what we think of for the risk of thrombosis in COVID-19 infection really seems to center on the fact that patients are becoming sick, they're hospitalized, they're immobilized, and they may have other comorbidities that make them susceptible to a severe COVID-19 infection that can predispose to DVT or PE.
Issue applied in Ecuador. The New England Journal of Medicine has featured a report of 3 COVID-infected patients who developed peripheral and central infarct with the antiphospholipid antibodies. All patients were hospitalized in Wuhan, China. There are not reported cases in Ecuador.
News medical contributor Dr. David Agus has been in contact with the White House about the coronavirus, and he joins us from Los Angeles to discuss the federal government's response and also getting enough medical supplies to tackle the virus. Doctor, good morning. I'd like to begin with something people have not heard a lot about, and that is the possibility of an antibody test to tell if the virus has been in somebody's system. How would that work, and why might it be helpful?
Well, across the country now, many people are having mild symptoms and are told to stay home because of the shortage of tests, and they're not being tested. And so at some point, you have to know whether you're exposed to the virus or not. And in the next several weeks, this test will be launched. Hopefully, it's even sooner. And the power is, if you've been exposed, what we know is for several months at least, we don't know the long term, but several months you are immune to the virus if you've already been exposed and recovered. So in a sense, we could create a cohort of workers across the country to be the ambulance drivers, to check out to at the grocery stores, working in the emergency rooms, who won't get sick if they're exposed again to the virus. So this test is critical to round 2 of fighting the virus.
We're hearing more and more stories, David, about healthy people who have it, who are passing it on. Idris Elba just did a big interview with Oprah where he said he had no idea that he had it. He's passed it on. We've heard about basketball players that have tested positive, feeling very healthy. There are reports that they've passed it on. How do you deal with something like that?
Well, that's difficult because when you don't know you have it, you need to do well, but you go out and you actually take liberties that you probably shouldn't, and you can spread the virus. And so that's what we're concerned about. But those people also can be our front line because they're not going to get the virus again, at least in the short term. They're, as volunteers, helping all of us to protect the elderly and the people with medical conditions who can't get the virus because of what could happen to them.
Why is 15 days the magic number? We keep hearing 15 days, 15 days. Why is that the magic number, and how realistic is that really?
That's a great question. The answer is we just don't know. So when we make interventions like we all have done this last week, the whole country has come through in such an amazing and positive way, is classically it takes 7 to 10 to 12 days to see the impact of those changes on the virus because of the incubation period of the virus. So the assumption is that 15 days we'll know where we are. And the hope is we've dramatically decreased spread of the virus. If we decrease spread of the virus, we're not going to overwhelm our medical infrastructure. We've been given time to develop drugs that will work in terms of treating the drug and preventing it from being spread. So we need that time.
Conclusion. COVID-19 cases. Coagulopathy and antiphospholipid antibodies in patients with COVID-19. There are just 3 cases, but it is important to understand its physiopathology because there is a chance that other cases could appear.
Knowing who's developed an immune response to the virus is really an important component of our public health response to this pandemic, allowing us to better understand the transmission characteristics and knowing how many individuals have actually been infected versus who maybe didn't develop symptoms, and how this percentage of individuals changes over time. And then on a more patient by patient basis, an important component of these serologic tests is identifying individuals who have antibodies to SARS-CoV-2 would make them eligible to donate plasma, which can then be administered to sick individuals to help fight off the infection. Because we've really only been dealing with this virus for 4 or 5 months, we don't have a good sense of the duration of that protective immunity that you're talking about. I think we can say that based on prior studies during the SARS outbreak in the early 2000s, we know that protective immunity against that virus, which is closely related to SARS-CoV-2, that protective immunity seemed to be detectable for about 2 years after infection. And then there's been some preliminary studies in monkeys suggesting that they have at least short-term immunity 1 month after recovery from COVID-19. So data are emerging, and I think, as we see more and more information, I think there will probably be at least some short-term immunity, but we really need more studies in this area before we can make any conclusive comments on the duration of that protection from reinfection. These individuals that are positive for antibodies to SARS-CoV-2 or to COVID-19, while I think they're likely at lower risk for reinfection compared to an antibody negative individual, we still really don't understand or know the level or the duration of protective immunity that these antibodies give us. So I think antibody tests will ultimately be another tool for risk management and risk assessment as we develop plans to get everyone back to work. But right now, given what we know, I would be cautious against relying solely on a serologic test result to guide these decisions and these recommendations. We actually have a testing capacity of approximately 10,000 antibody tests per day between our internal Mayo Clinic practice and the external Mayo Clinic reference laboratory practice. So that's quite a lot. And really, I think as the need evolves and increases, we do plan to be able to meet that need and increase our testing capacity as appropriate.
Thanks.